challenge we are tackling on this session is about integration. And we hear a lot of good things that you've done down in New Zealand, and I just thought we should probably start first by asking you to tell us something about the Midland Health Network.
Sure. Look, the Midland Health Network, as you introduced it, is a general practice governed and owned network that covers around about 400 general practitioners and about 100 practices across the middle part of the North Island. And really its purpose is to operate as a quality-based network, but also to try and standardise and bring about some capacity in the primary care kind of space to be able to participate collectively with the broader health system. It's really difficult for a funder or a hospital to try and interact with hundreds of small providers. But if you've got some infrastructure that's got some consistency, it's got some systems and got some capacity, it obviously makes the conversation more doable. And we're spread across what we term as district health boards, so we're spread across 4 of them. I mean, you know, what's typically happened in New Zealand is that you have a funder who's slightly suspicious of general practice.
Same here.
You know,
yeah.
It's a bit of an international disease, I think. A little suspicious and unsure of what's going to happen. A lot of that's often based on history, but also based on the fact that, you know, general practice in New Zealand is run on, as we term it, the kind of corner dairy model. So small independent businesses that may not have the infrastructure or the capacity to ensure they've got consistent kind of systems. And so what we're doing with the alliancing space is that we're breaking down that paranoia by taking away a lot of the rules and creating a lot more flexibility around how funding can be used. That's taken quite an effort. You know, the funder has had to step back from that command and control kind of role and writing those sort of phone book style service specifications on how thou shall do it. And it's also required primary care to step up and get more consistent about how it does things. What's been fascinating to watch is often, you know, a GP who's looked or worked alongside a colleague and has for many years understood that they did things differently or didn't do things, but never kind of taken them on around some of those issues. What we're seeing now is much more collective accountability for performance kind of coming up and being driven through the primary environment.
What if the payer is trying to come up with an alliance contract with you and the secondary providers together? Have you had examples of this?
So probably the best example is around cardiovascular management. So, you know, primary care's in the past been tasked with, you know, undertaking risk assessments, and then the management of complex patients has then been a bit of a jiggery-pokery referral into secondary, you know, mixture of kind of specialist nursing kind of services that some are run by the hospital, some are run out in primary care. So what we've done is we've formed what we term as SLATs, which is a strange term, but it's about service level alliance teams. And what we've done is essentially locked primary and secondary clinicians in rooms and got them to map out patient pathways. And then they've come out with a set of recommendations around how the service could be constructed, and then they've brought that back to the alliance table, essentially guiding the commissioning kind of role that the alliance team will take. And that's resulted in, using that flexible funding that I was referring to purchase things, as I've already said, much more consistently, to move away from the spot purchasing. But also it's seen some services starting to shift away from being hospital managed, so that if the secondary specialists have got more confidence that primary care understands how to use some of that specialist support, they're happy to push them further into the community rather than holding on to them quite closely in that secondary environment.
Okay. So the message here is a contractual arrangement like this is better than an organisational integration.
I think what this will lead to for us, we're starting to move into locality planning. We've got a lot of fragility in the primary care infrastructure, as I said before, a lot of small businesses. Yeah. We've got our hospitals are running out of capacity. So we've got to work smarter collectively. And a lot of that will end up being about integration. So, we'll look at moving renal dialysis and all the metabolic and diabetic specialist services out of hospital settings. Sure. And place them in newly built primary care facilities. You've got to integrate services, not just co-locate. And I think the alliancing space is allowing us to really look at how we can integrate the services by designing collectively. We're also, you know, the bulk of our income is capitated income. We've moved completely away from fee for service. And so with that, we're trying to shift the mentality away from volume-based contracting for anything to outcome-based contracting. Now, that's often easier said than done, but you know, we're trying to get and incentivise practices even internally to move away from paying themselves on the basis of what they do as opposed to what they affect. And so, yeah, helping them also redesign their internal business models has been a big part of what the network's been involved in. And that's kind of led to us also stepping in around ownership as well. So the network's ended up being a partner with a number of practices in terms of an equity partner and come in, and that's enabled us to standardise IT and standardise a lot of the other systems, which otherwise are a bit ad hoc in the way that primary care tends to operate.
John, can I thank you for being up so late, and we all wish you a good night. Thank you.